Asa na ka? Namin sa 306, ikaw rin walang dire.
Guys, asa na mo? Hello, Zam. Siya mga namo sa room 306. Ngit-ngit lagi kayo diri, wala pag yung tao. Naman mo?
Yes, Gab, naman sa 306, asa na ka? Mag-sure, oy, naman ganda nila sa 306.
Hello, Zam. Wala yun to. Hello? Zam, choppy ka do. Hello?
Wait sa. Mangita sa kutsada nga signal, ha? Oo, kani. Anak ko ba nga?
Hello, Zam. Okay na, klaro na. Hello? Alan na, lo. Sa ganito? Sa ganito? Cheers. Sana sila box. Hello, asa mo? Ma'am? Ba't ba? Ma'am? Ma'am? Ano ba? Ma'am?
Uy, Gab, nabasa ka dire?
Agay!
Uy, nabasa ka?
Sakit kaya kung kaning dali sa temporal area.
Okay ra ka?
Ay, sakit kayo.
Uy, Gab! Uy!
Gab.
Gab! Uy, Gab, naunsa ka? Uy, ano nabot kag SBM? Kani hara ba may nagsugod? May gani, nakita ka ni Jack, nangihi siya dito.
Ha?
Asa man na ka na? Isay? Luto isay, okay? Yes, Gab.
GM, a 25-year-old male who complained of having severe headache. GM came for consult due to a severe headache that he explained as sharp with a feeling of being stabbed by an ice pick at the temporal area of his head, accompanied by a complete vision loss on his right eye. Few hours prior to consult, patient had experienced headache and visual loss that, according to him, happened when his friend pointed out a flashlight directly at his eyes when he was walking at a dark corridor of his school. For his past medical history, GB claimed to have a history of having migraine for 3 years. For his family history, he had an older sister with a history of migraine. GB is currently enrolled as a second-year medical student. For his physical examination, his vital signs were blood pressure of 110/70, heart rate of 92 beats per minute. His neurological visual fields were full, with normal fundi and the cranial nerves were intact. Bright light from pen light precipitated an episode of headache with loss of vision. His imaging had no abnormalities in the CT. For the pertinent data, he is a 25-year-old male with a feeling of being stabbed by an ice pick at the temporal area, complete vision loss of his right eye. Vision loss was precipitated when his friend pointed a flashlight directly at his eye in the dark corridor. 3-year history of migraine. Sister had a history of migraine. A blood pressure of 110/70. Cranial nerves were intact, and no abnormalities in the CT were seen.
Diagnosis of primary stabbing headache. The diagnosis is based on the clinical features and the distinction from other similar headaches. There are neither biological markers nor neuroimaging findings. The diagnosis is entirely based upon assessment of the clinical features. The International Classification of Headache Disorders, 3rd edition or ICH-T3 diagnostic criteria for primary stabbing are the most sensitive to capture only primary headaches causing stabbing pain. It is also the latest criteria used for diagnosis and differentiating stabbing pain from other types of headaches. ICH-T3 defines stabbing headaches as transient and localized stabs of pain in the head and occur spontaneously in the absence of organic disease of underlying structures or the cranial nerves. In this criteria, it is required to have all of the following statements from A to E. A. Head pain occurring spontaneously as a single stab or series of stabs and fulfilling criteria B and C. B. Each stab lasts for up to a few seconds. C. Stabs recur with a regular frequency from 1 to many per day. D. No cranial autonomic symptoms. E. Not better accounted by another ICH-T3 diagnosis. And for the criteria of probable stabbing headache. A. Head pain occurring spontaneously as a single stab or series of stabs. B. Do only of the following. Each stab lasts for up to a few seconds. Stabs recur with a regular frequency from 1 to many per day. No cranial autonomic symptoms. C. Not fulfilling ICH-T3 criteria for any other headache disorders. E. Not better accounted by another ICH-T3 diagnosis.
So, there are various studies by Rasmussen BK and Olsen J of 1992, Pereira Montero G. Cepellas of 1995, Jasad et al. 2001, and Pareja J.A. et al. 2010 have reported different numbers in terms of the prevalence of idiopathic stabbing headache, but it ranges from 0.2 to 35%. The most notable of these studies is the one by Jasad O et al. of 2001, also known as the Vega study, as it is the largest epidemiological study on idiopathic stabbing headache, and concluded that it has a prevalence of 35.2% out of their 1,838 individuals. Reasons for these variations in terms of their prevalence is because PSH is commonly associated with other headache disorders according to Dodig TPJ of 2006. He also concluded that 42% of the patients who have migraines also reports with PSH. There are limited studies that focuses on isolated cases of PSH, and according to Liang et al. of 2014, 1.5% of the patients at a tertiary neurology clinic in China complain of PSH alone. Tugba et al. 2008 also reported that 12.6% of their patients in a Turkish headache clinic reported isolated PSH. Unfortunately, there have been no epidemiological studies of ICH in the Philippines. In the adult population, PSH occurs more commonly in females, with a female-to-male ratio of 1.49 to 6.6:1. The mean age of onset in the adult populations has varied significantly in different studies and has ranged from age 28 in the largest epidemiological study of patients in Norway to age 47 in a smaller study of 38 patients in Spain, and also to age 53 in a veterans hospital of 80 patients in Taiwan. Pediatric cases of PSH have also been reported. However, it occurs less frequently in children in comparison with adults. In children, the mean age of onset is ages 4.5 to 9, and unlike the female predominance in adults, there appears to be no gender predominance in children.
For the clinical manifestation of primary stabbing headaches, the essential features of primary stabbing headache are stabbing pain confined to the head or rarely the face, lasting from 1 to many seconds and occurring as a single stab or a series of stabs, absence of associated cranial autonomic features, and absence of cutaneous triggering of attacks. A pattern of recurrence at irregular intervals ranging from hours to days. The pains have been variously described as ice pick pains or jabs and jolts. They are more common in patients with other primary headaches such as migraine, the TACs, and hemicrania continua.
Pathophysiology. PSH pathophysiology is still unknown, which is why it is also known as idiopathic stabbing headache. However, various mechanisms have been proposed. Irritation to the trigeminal and extra-trigeminal nerves, as well as intermittent impairment of central pain processing, can result in neuron hyperexcitability or spontaneous synchronous discharge. With the perception of stabbing pain, emphatic impulses are thought to flow to the corresponding peripheral nerve distribution. PSH with migraine, for reasons unknown, causes a wave of depolarization in a region of the cortex which simultaneously increases blood flow to that region to match metabolic demand. When a depolarizing wave passes over trigeminal and extra-trigeminal nerves, it causes an antidromic release of neuropeptides. This is called the trigeminal vascular theory. Neuropeptides such as serotonin are directly released on dural blood vessels, resulting in neurogenic inflammation. This causes a decrease in the response threshold of primary nociceptive neurons in the dural blood vessels. This is known as peripheral sensitization. Normal intravascular pressure pulsations then inappropriately activate dural nociceptors, resulting in paroxysms of stabbing headache. Other theories for the pathophysiology of stabbing headache include dural sinus stenosis and brainstem inflammation or focal demyelination. However, these theories would suggest a secondary etiology for the stabbing headache.
For the treatment and prevention, the response to indomethacin 25 to 50 mg 2 to 3 times daily is usually excellent. As a general rule, the symptoms wax and wane, and after a period of control on indomethacin, it is appropriate to withdraw treatment and observe the outcome. It is not known why indomethacin is effective, but it must exert its effect differently than other non-steroidal anti-inflammatory drugs. Unique properties of indomethacin include the ability to reduce cerebral blood flow and decrease the cerebrospinal fluid pressure.
Primary stabbing headache is considered to be an indomethacin responsive headache syndrome. Furthermore, the response to indomethacin is variable, ranging from complete relief to not at all in 35% of the cases. However, indomethacin remains the first choice of treatment. There are few alternatives for patients unresponsive to indomethacin treatment or who have a contraindication. These are antiepileptic and antidepressant drugs. There are also some studies that have suggested agents such as cyclooxygenase 2 inhibitors, gabapentin, nifedipine, paracetamol, and melatonin, which might also be an effective alternate treatment option.